So let us talk about the management of bladder pain syndrome. Again, I am Dr. Salil Khandwala from Advanced Urogynecology of Michigan. We talked about the reasons why it happens. We talked about the diagnosis of bladder pain syndrome. Now it is a handshake. It's you and I have to do this together. It's impossible for one of us to do it just by oneself. The American Urology Association has put up these nice little guidelines. I know you cannot read it, but I'll go over these different steps. So if you can just see, it has a first line therapy, second line therapy, and we'll go over 1, 2, 3, 4, 5, one after the other. This is the one that I came up with, is the management. We talk about the dietary changes, then the stress relief and everything else. So the food diary is important. So it's maintaining a diary to record the food intake and its association with pain can be useful to identify if certain types of food cause symptoms to flare up. So there's certain types of food can do that. So I'll give you a list what are good BPS friendly, what are not to be avoided, especially anything citrus, like lemon, anything spicy could be an issue, like alcoholic beverages, caffeinated beverages, like citrus fruits, like grapefruit, oranges, and mustard, miso, soy sauce, vinegar, cayenne, hot curry. So those are the things that could basically bother the bladder. So now once you know this, you can pick and choose and see what could be in your case that you need to avoid. So dietary changes and keeping a food diary is important. Then we come to first line therapy, which is very important. General relaxation and stress management. This is key. Stress is very important cause of bladder pain syndrome, and controlling stress helps a lot with bladder pain syndrome. Then pain management, patient education. So we've done the education about how you get bladder pain syndrome and what C fibers and what are the behavioral modifications. So the dietary changes I mentioned to you, avoiding certain food items, and then using Urabel or Pyridium or over-the-counter Preleaf. It's almost like a heartburn pill for the bladder. You have something spicy and you forgot and you say, oops, now what? Well, you can take this Preleaf and it helps decrease that irritation, or even quercetin, which is an isoflavonoid that could help with the bladder. These are over-the-counter stuff. Yoga is very important. I teach yoga and I'm a yoga teacher and certified. So stress management is important because you do not really want to get into too much stress. You want to abate the stress somewhere here. It's good to have some stress, but not too much. And that is where meditation, mindfulness, yoga therapy comes very handy. The second line therapy are medications of different types. So the most common medication that is used for this is called amitriptyline or Elavil. You can see this is the synapse. This is a nerve and that's the membrane. And what happens is as the signal comes down, when there's initially there is release of this serotonin is released here at the synapse. And whenever it's released, that can result in a problem and can cause discomfort and pain. Blocking the reuptake. So once it's released, you're preventing its reuptake. So SSRIs block the reabsorption of serotonin, and therefore this gets wasted and it doesn't reform those vesicles. So that is what it does. See how it's preventing it from getting back into those vesicles, because as long as it empties out, that's initially you may have a little discomfort, but once it empties, this gets washed out, and now there is no more serotonin left to go back in. So that's how it works. The dose, sometimes I even start at 10 milligrams, but 25 milligrams is usually a starting dose, with going up to 75 milligrams or even up to 100 milligrams. The main side effect is drowsiness. And in a study, they showed that 60% had significant improvement compared to 47% with the placebo in the symptoms from baseline. So even though amitriptyline is a tricyclic antidepressant, it works very well for the neuropathic pain associated with bladder pain syndrome. So not only will it help with the discomfort, the pressure, the pain, but also the elements of urgency and frequency. Now, there are a lot of these tricyclic antidepressants that could be helpful. Now, the most adverse events are on this side and the least are above. So that's desipramine, nortriptyline. So sometimes I may use this, amitriptyline. So I've used 1, 2, and 3 typically. Hydroxyzine is more of an antihistaminic. I've not had much success with that. We start at 25 milligrams. It can also cause a little drowsiness. but the success is only about 30%. Now, at one stage, Elmiron was used a lot, and what it does is it sort of recreates the gag layer, but it takes a long time to work and it's expensive, and lately the results have been conflicting. So a very large recent multi-center study that was done on almost 400 patients showed that it had no benefit compared to placebo. There's no improvement at all. And recently, there are also reports of pigmentary maculopathy at the retina in the eye and leading to visual disturbances if with long-term use. So, and it happens about 1 in 6 people. So, I've given up essentially on using Elmiron for bladder pain syndrome. So that's where the second line therapy was. Now we come to the gabapentin and for neuropathic pain. And how does that work? These are two very good medications for neuropathic pain. If amitriptyline is not tolerated or amitriptyline cannot be given because patient is taking an antidepressant, then we could go to gabapentin or pregabalin, or this is called Neurontin, pregabalin is called Lyrica. So you see typically what happens here. So again, this is the nerve ending, and you can see at the synaptic junction, if this is called the alpha to delta subunit. Now, when that gets stimulated, the calcium channel gets activated and there is influx of calcium. So when calcium goes in, it breaks open these vesicles and releases the neurotransmitters, which could be glutamate substance P, which is a pain-producing substance, or noradrenaline. So when that gets released, it can cause more discomfort and pain. Now in pregabalin or gabapentin bind to this alpha to delta subunit, it prevents this calcium influx. Now you can see it's not that much of neurotransmitter coming out, and therefore you do not have that effect at the post-synaptic end. So this is the junction between the nerve and that ending. So clearly, that's how these two medications work. Neurontin or gabapentin is mainly for patients with pelvic pain and pressure. It's a 3 times a day dosing, and it's titrated to efficacy and side effects. The main side effect is dizziness and drowsiness, and the dose you can go up to 1800 and sometimes even 2400 milligrams. But this is a typical dose. Usually I go up to 1800 milligrams, but by the time most patients have noticed improvement. Lyrica or pregabalin, similarly, it is twice a day dosing starting at 50 milligrams and increase the dose gradually until we reach 150 to 300 milligrams daily maximum. So again, the side effect is mainly drowsiness, and that is usually well tolerated. Another treatment is pelvic floor therapy. Now, remember I mentioned about pelvic muscle spasm in the introductory video and the bladder pain syndrome introductory video. So that would help with it. It helps somewhat with the urgency and frequency. It helps break the spasm down, and it fatigues those muscles with continuous stimulation. The other therapy is actual bladder therapy. This is bladder instillation. So you put liquid into the bladder, and this is a very powerful anti-inflammatory agent called dimethyl sulfoxide or DMSO. That's in the bladder. Heparin is another bladder stabilizing agent and anti-inflammatory, as is this steroid, the Kenalog or triamcinolone, and lidocaine, which is a local anesthetic. So we use a combination of this weekly or bi-weekly. This is put in the bladder. It takes about like a few seconds to put it in. Patient then holds it for about 20 minutes. We just put it into a tiny little catheter, take the catheter out. She holds it for about 20 minutes, and then she urinates. That helps tremendously with the bladder because it helps take away the pain-producing substances. Sometimes there may be a garlic smell because DMSO is released from the skin and gives that garlic smell. But 93% objective improvement and 53% subjective improvement has been seen with bladder installations. So after amitriptyline, bladder installation and gabapentin or pregabalin could be effective. Another thing that sometimes we use is called hydrodistension, and this is part of either a second or third line therapy where in the operating room this has to be done because the bladder is filled up. So what we do is we put you under anesthesia. We fill the bladder with the telescope that I just showed you, and especially with low bladder volumes, then we allow it to passively fill. We're not forcing it. It goes in slowly into the bladder, and we let it fill to whatever it is. Now, sometimes in your diaries, you may go at 150 ml, and that's it. But under anesthesia, the bladder muscle may be able to stretch to about 500 cc's. Now remember, the nerve endings are quiet because you're under anesthesia. If you're awake as the bladder stretches and the nerve gets activated, it'll cause you the discomfort. But here, since the nerve is asleep, the bladder muscle can do what it wants to do. And we are not forcing anything. We're just letting the muscle take over. And it fills up. We hold that for about 3 minutes, that distension, empty it, and redo it. Just doing that can reset the C fibers and it can repair that gag layer. So it allows the bladder muscle to stretch to its own capacity and by bypassing the nerve pain because the nerves are asleep. If at the time of that hydrodistension we see these Hunner's ulcerations, then we can actually inject a steroid into the ulcerations to help its healing, and that may also help with the urgency, frequency, and the discomfort. It takes only about 30 minutes to perform. Patients are sent home within the hour of the procedure. The chance of having any bladder injury is very rare because we do not do high pressure distension, it's low pressure distension. Bladder infection can happen, but it's unlikely, and patients rarely have difficulty emptying the bladder. What we've seen is 60% of patients will come in and they'll say that they are satisfied with the improvement following the hydrodistension. The fourth line therapy is something called neuromodulation. Now, that could be Botox in the bladder, inner-stim neuromodulation, or leg stimulation. The inner-stim neuromodulation is putting a little battery in the buttocks, and that stimulates the nerve by putting a small lead there. And it is associated with significant reduction in pelvic pain frequency, nocturia, urgency, and interstitial cystitis problem score. With overall pooled treatment success rate was 84% according to the study, which was published in 2017. What sacral neuromodulation does is it inhibits these bladder afferent impulses from being recognized too much. And when the pain nerves are not being recognized, then you do not perceive pain. The Botox also is very interesting because it not only helps with the urgency and the frequency, but it could also help with the pain. So it's injected not in the trigone, but above the trigone. And once you inject it in, what it does is typically what happens is there's increased level of these pain-producing neurotransmitters, which induce what is called neuronal hypersensitivity. They make the nerves very excitable, especially the C fibers. Botulinum toxin type A, which is Botox, inhibits this neurotransmitter release and from these afferent nerves, and thus decreases the sensitivity experienced. So the nerves do not get that sensitive if the pain-producing substance is not released, and that's what Botox helps. And it also helps with the bladder contractility. So it helps not only the pain element, but also the urgency and the frequency element. So when you look at success defined as being moderately or markedly improved on what's called a global response assessment, there's 72% reported success with Botox. The nerve stimulation is by putting a little acupuncture-like needle just above the ankle on the inside of the leg, and that stimulates the tibial nerve, and that also modulates the bladder nerve. So clearly there are many options available, which start from dietary modifications, keeping a food log, avoiding food irritants such as caffeine, spicy food, citrus food. You avoid that. Take some food items orally over the counter, such as pre-leaf quercetin, that could sort of offset some of these food items. Stress relief is very important. Pelvic floor therapy if there's a muscle spasm. Medications we talked about, amitriptyline is like the first one, and the Neurontin Lyrica is a good option. Elmiron I've sort of given up on. Bladder installation, very, very good. And then if it's still persistent, then for the urgency and frequency, we'd go with Botox or inner-stim. Even for the pain associated with the bladder, Botox would be helpful. And then if it gets more complicated, then we go into the further, whether it is intravaginal diazepam, if there's a pelvic muscle spasm, and that would help. Sometimes even trigger point injections or Botox injection into the pelvic muscle would help with the muscle spasm. In refractory cases, then they would be referred out to a specialty pain clinic. But I think most of these cases can be easily managed, but all this has to be done. Cannot be just depending upon one medication and that's it. So what is our role? How do we help you? Now, we look at our role and your role. So what is your responsibility? You got to do the voiding diaries and send them to me so I can review it. You may get the Q&As after this to go on my chart and answer those and send them to us. and instead of set your appointment for the initial assessment, the preview visit, make the appropriate dietary changes, go in for some mindfulness yoga program, prepare for flare-ups. If you know something is going to happen, just prevent it by taking Prelief or quercetin or even pyridium. And realistic expectations are the flare-ups can happen. It's never going away. But as long as you mitigate them and control them, that's good. So ultimately, yes, we can give you medications, but then also you have to titrate against the potential side effects. So our responsibility is to get your feedback questions and see what you've written and help you there, and also look at the avoiding diary. So this is basically, once you watch this video, I'm just giving a few little questions to answer, and that helps you sort of understand what we're talking about. Set up the pre-consult visit, then direct you to the correct portion of the management, and you can say, okay, now where do we go? Level 1, 2, 3, 4, or is it all together? Make sure there's no infection. You can get this discussion done virtually on doxy.me, and then we'll set up the visit. So my goal is to get you in within 1 to 2 weeks of getting your first visit. You send me the diaries. That's very, very important. I know it's over 4 days, but you can do that 24-hour where you have to measure it at home, which could be a Saturday or Sunday. But the remaining 3 days, you just need a paper and a pen. So you could do it from anywhere. So a detailed history and comprehensive exam helps make the diagnosis, management, many factors. Don't forget dietary and stress is key, then medications, flare-up control also. But it's very common. And the biggest problem and the sad thing is it's often misdiagnosed for sometimes years as bladder infections. When we see them, sometimes they come with a flare-up. They'll have urgency and frequency. It sounds exact like a UTI. But when the urine is sent for culture, it is completely negative. Endometriosis, there's no such thing, because that's again a neuropathic condition. Sometimes they undergo a hysterectomy for pelvic pain, which was probably unnecessary because the pain is still there after the hysterectomy. And they may perceive that sensation of something falling out of the vagina and think it's a bulge or a prolapse. And sometimes there may be a little bit of a bulge. And if you do not know the condition, the surgeon may make a mistake and operate on that bulge and just worsen the problem because the nerves get more irritable. Now, there are some situations that I will see myself, a patient with a bulge, but she has a lot of urgency and frequency, and she has bladder pain syndrome also. I would then make sure that she understands the difference between the bulge and bladder pain syndrome. One is a nerve condition, one is just a weakness condition. The key would be to correct the bladder pain syndrome first. Once it improves, maintain it, and then if the bulge is still bothersome to her as a physical presence of something hanging down, then I would repair the bulge. Otherwise, I would be very concerned about repairing it right away because it'll flare those nerves up. Bottom line is that it's a handshake. You and I work on it. We can get this improved. We may never get it cured, but as long as we can improve the symptoms to your satisfaction, that is the goal.